Well, good day to everyone joining us, and welcome to today's X-Talks webinar. Today's talk is entitled GHQ-12, General Health Questionnaire, a validated psychiatric screener to quickly identify signs of distress. My name is Ryan Muse, and I'll be your X-Talks host for today. Today's webinar will run for approximately 60 minutes, and this presentation includes a Q&A session with our speakers. Now, the webinar is designed to be interactive, and webinars work best when you're involved. So please feel free to submit your questions and comments for our speakers throughout the presentation using the questions chat box, and we'll try to attend to your questions during the Q&A session. This chat box is located in the control panel, which is on the right-hand side of your screen. And if you require any assistance along the way, you can contact me at any time by sending a message using the same chat panel. At this time, know that all participants are in listen-only mode, and please note that the event will be recorded and made available for streaming on xtalks.com. At this point, I'd like to thank Mapi Research Trust, who developed the content for this presentation. Mapi Research Trust is a nonprofit organization that promotes the use of clinical outcomes assessments in health research and practice and encourages exchanges of patient-centered outcomes and COA information among academics, pharmaceutical companies, healthcare organizations, and health authorities. With the web-based platform eProvide that includes the databases ProCollid, ProLabels, and ProInsight, Mapi Research Trust has become the preeminent source of reliable, up-to-date, and comprehensive information about COAs. Now I'd like to introduce our speakers for today's event. Dr. Tom Roberts is an American emergency medicine doctor based in the UK. He established the UK's largest emergency medicine research network, funded by the Royal College of Emergency Medicine. He has extensive research experience and publications in the field of distress, trauma, and fatigue in frontline doctors. This includes the use of self-administered research tools, including the General Health Questionnaire. His research has recruited almost 10,000 frontline doctors since 2018. And Frédéric Boucher establishes new collaborations with developers and copyright holders of clinical outcome assessments and assists them with the daily management of their questionnaires. She manages European, Canadian, American, and UK accounts, including the management of the scales developed by GL Assessment. Prior to this, she has worked for the past 15 years in the linguistic validation of COAs at Mapi Icon Language Services. Now, we have a poll question before we move on to the main presentation today. Appearing on everyone's screen right now is this question, and audience members, you can interact with this in real time by selecting on any of the answers that you see in front of you and then clicking submit. The question that we're asking is, have you used the GHQ-12 in your own work before? Your answer options are yes in clinical practice, yes in commercial practice, yes in academic research, or no, I have not. We'll give everyone some time to consider their answer as it best applies to you and your work. Again, the question is wondering, have you used the GHQ-12 in your own work before? Looks like most of you have an answer in. Thank you very much for participating. We'll take a look at these results after hearing from our first speaker for today. So without further ado, I'm going to go ahead and hand that over then to our first speaker, Dr. Tom Roberts. Dr. Roberts, you may begin when you're ready.
Hello, thank you very much. Thank you for that kind introduction, and thank you to both Mapi and to GL Assessments for inviting me to speak today. As Ryan said, I'm an emergency medicine doctor in the United Kingdom, and I've been asked to speak today due to my experience using the General Health Questionnaire 12. Just a couple of disclosures, and thank you so much for asking me to speak today. It's a real pleasure, and I'm so glad to see that there was over 300 people registered for this event, which generally shows how interested people are in mental health and how important it's becoming across the world in terms of both as something to look at clinically and also as research. So these are my disclosures, all opinions of myself, and let's get started. Let's focus in on the GHQ-12. So I'm going to start with a story about why the GHQ-12 worked for my research. We're going to then really nail down into what the GHQ-12 is, how it's scored, and what it actually measures. And then we're going to, at the end, understand when you might want to use it and its limitations. So in the introduction, Ryan said that I've done extensive research into mental health and into fatigue. In 2018, I was leading the UK's largest research network in emergency medicine. And come 2020, we had a study looking at headaches, not mental health, but headache in emergency departments. But if you cast your minds back to January 2020, COVID had begun. And I was actually in a research meeting down in a place called Taunton on the M5 motorway to discuss this big headache study. At that time, it became apparent that clinical medicine, so hospital medicine, general practice, and research was going to change. There was a mandate in the UK that all planned research activity was to stop, and everyone had to look at COVID. So I had 100 hospitals, 100 emergency departments ready to do a research study, but suddenly that research had gone. So as I drove home, I thought about our strengths as a research network and what we'd done previously, and our work looking at over 4,500 emergency medicine doctors and fatigue and intershift recovery. That's where I realised our strengths were. There were other research groups looking at diagnostics in COVID, other research groups looking at drugs, but we could really make a difference if we understood how the COVID-19 pandemic was going to affect frontline doctors. So as I drove home, I got a list of people I had to get involved, including psychologists, other doctors, intensive care doctors, anaesthetic doctors. And within 7 days, we turned around this study called SERA. So we designed it, we wrote our protocol, we submitted it and got approval. And to do something that quickly, you have to look at key tools that you can use to measure your key outcomes. For me, we wanted to measure distress and trauma in frontline doctors. And the GHQ-12 was this simple, short tool that frontline doctors could use to answer some very important questions. The study was a success. These are all the publications. It got Frontline News. It was in The Guardian, which is one of our sort of national newspapers, and other sort of mainstream media as well. And it didn't only assess the rates of distress and trauma, so understand the prevalence. It also built into a new psychological model for psychological well-being for doctors. So we've used this data to inform how we're going to improve the care for doctors in the future. So now I touched on this very briefly, but I want you to understand why the GHQ-12 worked so well. So we recruited 5,500 doctors during this SERA study. So that's 5,500 doctors who were at the peak of the pandemic, who were really stressed, very busy. So you had to design a tool and a research study that they could complete. So the GHQ-12 was ideal because it's simple. So it asked 12 very simple questions, and it's got 4 possible responses. And because it's so simple, it means that people fill it in. And when people fill in surveys, you get better data. There are only 12 questions, so it's short, which was ideal for the work that we wanted to do. And then there's this idea of external validity. So what that means is, in that very quick turnaround between coming up with the idea of the study and designing the study, we had to look for a tool that had trust, that people, other researchers, other clinicians could look at and say, well, that was the right choice of the tool. So the GHQ-12 has been used in many, many populations, including other doctors, including during the SARS pandemic. So this tool we knew people would trust, and we could also compare it to other populations. So the key thing about the GHQ-12 is that you could administer it rapidly to thousands, if not tens of thousands of people. So a very brief introduction to what it is. This is the introduction. This is an example of a paper version. You'll see some examples here of questionnaires, of the actual questions down here, and then you can see these 4 responses. So it's asking you about your medical complaints and your health in general, and it's focusing in on the past few weeks. So it's looking at very recent symptoms. And the type of areas it looks at is concentration, sleep, do you feel useful in things, your confidence, your happiness. So these are very simple questions to answer. You don't have to kind of have a significant sort of availability of cognitive load. You can be very busy and still answer these questions. So that's why it works so well for my research. So moving on from the SERA study and looking at why it worked for me, I want to kind of now really dive deep so you can understand why the GHQ came to being, how it's specifically scored, and to understand the outcomes. So how do you interpret the GHQ-12? So the GHQ-12 was developed in the 1970s by David Goldberg and Paul Williams. Their original aim was they wanted to develop a screening test to detect psychiatric disorders amongst both community settings and general medical outpatients. So what they were aiming to do was to detect forms of psychiatric disorder that have a relevance to a patient's presence in that medical clinic. So what this really means in modern day speak, this is obviously how they described it in the 70s and 80s. This tool focuses on the psychological components of ill health. So it's looking at those things from a psychological perspective that will impact upon your general physical health. It was originally derived in London, but since then it's been validated in over 50 studies, and it's been translated into multiple languages. So it's been used in populations of rural Iceland farmers, Chinese-speaking university students, GP clinics in Calcutta. So no matter where you're sat listening to this, it's likely or possible that there's a study that has already been completed looking at very similar populations, and it's likely that there's an available version in your language as well. I just want to touch on this idea of psychiatric disorder because it's quite an antiquated old kind of phrase, psychiatric disorder. So I just want to break that down so you could understand exactly what the General Health Questionnaire is measuring. So the key thing to state is that the GHQ-12 is a screening test, it's not a diagnostic test. So the main focus of the GHQ-12 is to determine the difference between what the original authors defined as psychological sickness and those that have psychological health. So it's not trying to diagnose a specific condition. It's not looking at depression or anxiety. It's just differentiating people, screening people to say these people may well be well or these people might be unwell. More commonly these days, it's kind of generally used to identify psychological distress, as in that's what we did. But as I say, it's not a diagnostic tool. So it's trying to identify cases, or as the original author stated, this idea of caseness. So what this states is that psychiatric symptoms are on a spectrum, and we know that they're distributed amongst the population in varying degrees of severity. And what the GHQ-12 was trying to do is to identify a line, a threshold, where someone is a case and someone is not a case. And that will change depending on your population, depending on what other illnesses you have. That cutoff can be different from study to study. And this notion of hinterland, what that's picking at is questions are looking specifically at your normal healthy functioning. So what's normal for you? And it's also looking at appearance of new phenomena of a distressing nature. So these two different types of questions were specifically chosen so that they could identify patients that are psychiatric patients and patients or people who are non-cases. So it's been very well designed to differentiate between those two groups of people. Now it's important to say that the GHQ-12 measures transient symptoms. So they're not lifelong traits. It focuses in on breaks in what we call normal function. So it's all about when you measure the GHQ-12. Some disorders may improve with time, and that kind of impacts upon when you actually administer the GHQ-12. So that's a bit of a background in terms of why it came about and what the original aim was, and this notion of psychiatric disorder. And it'll make a bit more sense as we go into scoring, and then we'll look at the outcomes in a second. So there's two different ways that the GHQ-12 can be scored. So this 0011 method, that's called the GHQ method. And then you've got the 0123, which is the Likert method. And you can see down here at the bottom what that means. So when you use the GHQ method, which is at the bottom here, you can see that dichotomizes, that splits people into those that have symptoms, so symptoms that are negative, and those that have symptoms that are positive. So what I mean by that is you can see here that if you, in this question, have you been feeling sad and gloomy? If you have a response which is negative, so rather more than usual or much more than usual, they score 1 and 1. So it just puts you into that bracket. And if you don't have any symptoms, then it's 0 and 0. So it's splitting people into two different groups, those that are well and those that are unwell. The Likert scoring, 0, 1, 2, 3, what you can see this does is this will delineate better the severity of symptoms. So it will delineate between individuals and the severity of those symptoms, because as your symptoms get worse, you get higher scores. You'll see this in the next section where I discuss outcomes in a lot more detail, and it will make a lot more sense. So I just want to touch on thresholds. So we've discussed that the GHQ, the main point is to define if you're well or unwell. So in terms of how you define that level, that score which dictates a case, the best approach is actually to look at the literature and find similar populations. So as I said in the beginning, it's likely that someone's already done some research in your population or similar populations. And because thresholds differ between groups, it's interesting to understand what someone's done previously and their rationale. And why do thresholds differ? Well, it makes sense that they differ. So if you're looking at normal functioning, which the GHQ-12 does, and you have comorbid physical health, so say a lung condition, which means you can't walk very far, then it's likely that your threshold may well need to be higher to be distressed or have psychological illness, because your physical symptoms will also impact upon your score. And this has also been used in soldiers, it's been used in sailors, it's been used in farmers, it's been used in community settings. So you can see how you're setting where your patients or your research subjects are living and their environment, that might impact upon your threshold of whether someone might be distressed or not. So let's focus in on the outcomes. So we've looked at how the scoring is put together for each of the 12 questions, and then you'll get an overall score. And what you tend to do with that score, if you're in a research study, is you'll plot that in a graph, and you'll try and understand what's happening in your population. There's two different ways to display that information. So one is a categorical model and one is a dimensional model. So the categorical model, this is what I like to do as a doctor. So this dichotomizes those into who's a case and who's not a case. And that's helpful because I can then identify who's well and who's unwell. And then I can target either future diagnostic testing or future interventions into those that are unwell. The dimensional models, that's generally where you use your Likert scoring. That's useful because it gives you, the way you interpret that is generally using means and medians, so average scores, and then you can compare between different populations. So you can compare between your study and someone else's study, or you can compare between your study in say November and then your study in January. You can see how things have changed using the average scores of the different populations. So this is how that looks. So this is the results from the SERA study, and this is the categorical model using GHQ scoring 0011. So we cut a threshold at this red line here. So that red line is a score of 3. So everyone below the line is not a case, and everyone above the line is a case. So they are psychologically distressed. This is a dimensional model, so you can see how this looks different. So that 0, 1, 2, 3, that gives you a lot more detail and a lot more granularity around individual cases, and also around the dispersion, so the numbers of severely unwell participants or very well participants. So you can see those that are scoring very highly will be in this long tail here. So it's useful, and then you can compare the distribution of these scores. If you were to superimpose another graph on top of that, you will see how the average scores change over time, and you can see that potentially how the severity of scores might get better or worse with time. So using those models, how do you interpret the GHQ-12? So there's 3 main things you can do with it. So the first thing is to state a prevalence of psychological distress. That's how we used it in our study. So we took everyone to the right-hand side of the line, divided it by the entire population, and we said 51%, I think it was, at the time, were psychologically distressed. So that's one way that you can publish your data, and that's one way you can interpret your data. Another way is to say, well, I'm really interested in patients that have a high morbidity. So you look at patients with a particularly high score and you group them together, and you can understand that group a little bit better, and maybe you'll target specific interventions into that group. And then you can also look at it, and you can use the other dimensional model as well, so the Likert scoring for this as well. But you can then look at severity of disorder. So you can use this on an individual basis to identify patients who are particularly unwell and who would benefit from specific interventions or future work. So as I said, there's 3 different interpretations for your scores. So you can use it to identify prevalence of disease, morbidity within a population, and then severity of disorder amongst an individual. So in terms of your outcomes, it's important that you understand what might affect those outcomes. So we've already discussed how increased physical health and your setting might increase your threshold score or increase your scores overall. It's also important as the GHQ measures transient experiences and breaks in normal function, that the time since exposure or time between interventions and when your GHQ-12 is measured will have a significant impact on your GHQ-12 score. If I measured the GHQ-12 in a soldier an hour after he'd just been in a battle, his scores would be significantly different if I administered the GHQ-12 3 months later. And that just makes intuitive sense, but it's important that when you're reading the literature around the GHQ-12, you understand exactly when they administered it and what was their primary research question. And there are some issues around language that Frederic, the next speaker, can come on to, but understanding how well the tool's been translated, and Mapi are a great, one of the best in the business at translating tools. So understanding how language and your cross-cultural adaptations, how that might impact on your scoring is also important. So I hope telling you about the story of GHQ-12 and how we used it, and then sort of diving a bit deeper into how it's scored, is giving you some ideas of how you might use it in your work, be that your research or your clinical work. In terms of when it's indicated and when you should use it, so it's an amazing screening tool. That's what it was developed for, and it's great for screening thousands and tens of thousands of people. So if you're a large company or you're in charge of a large population, this is a way to identify groups of people who you should be significantly worried about. It's good to understand prevalence of psychological distress in a population, and you could administer that in different populations, compare populations, and see what might be different and understand the differences between populations. And it's also useful for follow-up. So I've already stated that your symptoms are likely to get better anyway, but if you are administering an intervention, you can understand on an individual or a population basis how people's scores are changing over time. The last thing to say around indications and limitations is the limitations of the GHQ-12 are generally the limitations of a screening tool. So what do I mean by that? Generally, when you publish and talk about screening tool data, they overestimate the prevalence of disease. And this is just the limitation of a screening tool. It's not specific to the GHQ-12. So it's not so much the GHQ-12 that's the issue, it's us as researchers. We tend to be very excited when we get our research results. We want to tell the world, we want to tell a really amazing story. But we have to be a bit careful with the GHQ-12 and with any screening tool. So as long as we remember to use it as it's designed and don't overstate our outcomes, then the tool works very, very well. Now, there are a couple of other versions of the General Health Questionnaire that I'm going to touch on briefly. So the first version is called the GHQ-28. 28 just outlines that there's 28 questions. Now this is useful because it's scaled. So if you're interested in these specific areas, so those are somatic symptoms, anxiety and insomnia, social dysfunction, and severe depression, these are separate scales and items within the GHQ-28 that will specifically target these areas. So if that's what your research question is, or if that's what you're interested in, then the GHQ-28 might well be for you. The GHQ-30, I would generally, if you're going to use the GHQ, a kind of middle-sized version of the GHQ, I'd just go for the GHQ-28, so don't worry too much about the GHQ-30. The GHQ-60, now this is something that, for the work that I do in emergency medicine and for the type of research I'm involved in, I think the GHQ-60, although it would give you a lot more detail, I personally feel it's too long as a research instrument. So to answer 60 questions as a participant, as a research participant or in a clinic, it's a lot. So you have to have high levels of literacy, you have to have a lot of time, a lot of concentration to be able to reliably finish a GHQ-60. There may well be times when that's indicated depending on your population, but you just have to be aware of those limitations. But it's very good for the more kind of intensive examinations of psychological distress. That's me coming to the end of my talk. Thank you so much for listening. I hope you found that informative. I hope you've got a better understanding of how the GHQ-12 now works as a screening tool. I really would advocate it as If you use it as designed, it is excellent. We have really, really good response rates from it. So in terms of being able to administer it on a large scale, it gives you a lot of information. And those comparable studies, so that external validity I talked about at the beginning, are so useful. So you can look at your data and compare it quite easily with lots of other similar populations. As I said, the strength from the GHQ-12 is how easy it is to administer. Thank you so much for your time. If you have any questions, you can reach me on Twitter or by email. And what I'm going to do now is, in a moment, we'll hand over to Frederic, who's going to talk you through how to get hold of the GHQ-12 and the conditions of use. I'm going to hand back to Ryan to go through the results of the poll. Thank you very much.
Thank you very much, Dr. Roberts. Very interesting presentation. And as you said, before we move on to our next speaker, let's look at the results from the poll question that we all participated in earlier. Should be appearing on everyone's screen right now. It looks like to our question of have you used GHQ-12, your answer options came out 78% for no, you have not, 17% for yes in academic research, and then 2% of you selecting both for yes in clinical practice and yes in commercial research. Very interesting results. Thank you all for participating. Now let's hand over our presentation to our next speaker, Frederic Boucher. I'm sending this to you now, and you may begin when you're ready.
Thanks. Thank you, everybody. So I'll present you how you can have access to the GHQ, the conditions of use, and the existing language versions. So the slides I will show you now are for the GHQ-12, but also to the other forms of the GHQ. Let me just. They all apply to these three instruments, and GL Assessment has appointed Mapi Research Trust, a non-for-profit organization, as the distributor of the GHQ and if its derivative. What do we call derivative? This is translations and electronic versions. So this work gathers the centralization and information on translations, the distribution and licensing of the instruments, and also the coordination of any new translations and electronic version. And this can be managed through our eProvide tool. So here is a quick screenshots of the GHQ on our eProvide platform and specifically on our Procolite page. The Procolite database is a Mapi Research Trust database that describes clinical outcome assessments, and currently in it you can find more than 5,800 instruments with information, as you can see, on, for example, the contacts and condition of use, a review copy, languages. So when you go on this page, you can go into access this questionnaire and you can submit a request here, and I'll go into a little more details afterwards. So how to access concretely the GHQ? So you can create your profile under the following link on eProvide. You create your client account by clicking on My eProvide, My Client Account, and then you will submit a request by completing a form. So you will be asked further information on the study, on the languages needed. We were mentioning in the poll question if you used it before. So is it going to be for a clinical practice, for a commercial use? This is the type of questions you will be asked. And you can attach any documents that you think may be useful for your request. And you will receive a receipt of your request by email. And one of our Provat team member will reply within 48 hours with the instructions on next step, so that you can then sign a license as quickly as possible. So the GHQ licensing process is a little more specific. It has a different process depending on where the inquiries come from. So let me show you. So we have a user requests to use the GHQ, be it for original questionnaire or translation. If the inquiries are originating from the UK, Republic of Ireland, and the Channel Islands, then the request for original questionnaire and thus the licensing will be managed directly by GL Assessment. And in parallel, if you need translations, you can ask them through eProvide. On the other hand, if you are a user requesting this from any other countries than the one on the left, then everything will be managed by Mapi Research Trust, and you can submit a request to have access to the original questionnaire and to the translations. So we were mentioning how we saw how to enter a request and what are the key steps for the licensing process. So if you are not a not funded academic user, then you click on submit a request, and you will have and you will receive an agreement. So you will sign a master user license agreement with Mapi Research Trust. Then you will sign a work order linked to this, what we call MULA, with the information on the study where you will use the GHQ. And then you will have licensing fees. So these are calculated depending on the type of license, if you will use it on a specific study or if it's for an annual use, the mode of administration, be it paper or electronic, the category of users, are you a commercial user and a healthcare organization, for example. And then once you have the permission to use, once all this process is completed, then Mapi Research Trust will be able to deliver you the requested language versions, original and translations, of course, if they are available. About translations, so the GHQ-12 has been developed into it has been developed into UK English, and we can see below the current available translations for the GHQ-12. We currently have about 62 languages available. This table is really a picture of what is it now. This is constantly evolving. So should you need any translation, please enter your request through the eProvide platform, and our team will be able to check the availability and status of each language version for you. So what if the translation you would like to use is not available? Then for commercial users, the production of any new translations must be exclusively developed by Mapi Research Trust's linguistic validation partner, which is Icon Language Services, following a thorough process, a validated one, and one which has been used for the past year. If you are an academic user, you will be authorized to do a translation by using again signing a master user license agreement. We will provide you with linguistic validation guidelines that you will be able to follow, and very important, you will send the final version to Mapi Research Trust, and other academic users will be able to use it. So for commercial users, of course, the linguistic validation partner, Icon Language Services, will provide a certificate that will be needed when you need to submit your dossier to health authorities. And very, very important point, all the translations of the GHQ are owned by the copyright holders and remain their properties. Then what about electronic migration? So for commercial users, the review of the screenshots is original screenshots. So what we call screenshots is what we see on the screen, and this is going to be reviewed exclusively by Mapi Research Trust for the original screenshots on a device, and by Icon Language Services for translated versions being migrated onto a device. For academic users, academic migrations are authorized, again, signing a license agreement and a specific work order. And again, Mapi Research Trust will provide generic electronic migration guidelines. Here again, same as for translations, all the electronic versions of the GHQ-12 are owned by the copyright holders, and it remains their property. To conclude, should you have any remaining questions on how to access the original questionnaire or the translations, or should you be interested in using the GHQ in your future projects, please feel free to visit Mapi Research Trust is eProvide platform, where you will find the description of the instruments and where you will be able to submit your request to use the GHQ. In addition to this webinar, you will be able to find complementary information in the handout that will be available for downloads. And if after this webinar you enter a request under the eProvide tool, could you please mention that in the notes so that we can track that you come through this webinar. Thanks a lot. We will be really delighted to help you, so please really feel free to contact us at any time, and we will be more than happy to help you in your research, in your studies. So thanks again to everybody today, and now we'd love to hear from the audience.
Yes, well, thank you both very much for this very insightful presentation. As we move on to the Q&A session, I'd first like to direct the audience's attention to the Handouts module within the GoToWebinar control panel, where you'll find some additional documentation related to today's presentation to download, including the links that I've put up on screen right now. So please take a look at that. I'd also like now to invite the audience to keep sending their questions or comments using the questions window for this Q&A portion of our webinar. I've already received some questions for you both, so we'll get ourselves started with those. The very first question I have here for you would like to know if they can use this in different age groups simultaneously.
I'm happy to go with that one. So yeah, so the GHQ-12 has been validated from adolescents all the way up to adults. So it can't be used in children. But it can be used in different age groups, and there's no reason why you can't use it simultaneously. The important thing with all of GHQ work is to understand, I know I keep saying this, but understand, has this been done in similar populations, and what did they do? Because a lot of the questions you'll have around your specific group or your specific cohort will already be answered somewhere through a validation study, and there's lots of factor analysis studies, there's lots of kind of psychometric testing of the GHQ-12 that's been continually repeated. So it's one of these tools where it's quite amazing when you start looking, because there's likely to be a study that answers your question somewhere, and in a lot more detail than I can possibly answer as well.
Very good. Thank you very much. A similar question, but looking for, I guess, more information. Someone's wondering if you can use the GHQ questionnaire for screening adolescents, but also in pregnant women.
Again, happy to come in on this. So it has been used in pregnant women. So we're happy to provide some literature on pregnant women. So there are studies where it's been tested and used successfully. So yeah, there's no reason why it can't be used in pregnancy.
All right, very good, thank you. The next question here would be asking, can the GHQ-12 be used with illiterate or blind respondents?
I'll hand that one to Frederica, I think.
Yeah, I take this one. Indeed, this can be this can be used with this category of respondents. Somebody would then read out the questions to the subject, and rather than reading out the whole response scale, it's easier to explain at the outset what the persons want to know actually, and what we measure is whether or not the things they are going to they have experienced this notion of more than usual. So you don't have to read out the response, but you really need to ensure that if they answer by yes or no, you are able to ask them if it's more than usual or not, to be able to evaluate on the scale. But simple answer, yes, you can, as long as somebody is reading out the questions to the subject.
All right, very good, thank you. Next question here wonders, can the GHQ-12 be used to measure positive mental health?
Yeah, so it can be. So there's studies out there which have used it kind of in the reverse. So rather than looking for psychological distress, have used it in the reverse. And you can see from the data we presented in terms of those models and those graphs, if you saw the big red line and everyone to the right of the line was psychologically unwell and everyone to the left by virtue are actually well. So you can use it in the reverse way, which is a really positive way to look at mental health as well. So that's great. I guess the ethical and moral question is, whilst it's great to look for positive mental health, if you identify a lot of people with poor psychological health, what are you doing with them, and what are you doing about them? But technically, there's good validation studies out there to use it the opposite way around.
Wonderful, thank you. The next question here is asking, if I haven't used any of the 4 GHQ scales previously, how would I know which one to choose?
This comes down to research question. So if it depends on your population and what you want to know. That's the best answer. So it's like any research study is, you have to start with a clear description of why you want to do it and what outcomes you're looking for. And then after you know that, it'll then become quite clear. If you just want to measure psychological stress quickly, easily, simply, then GHQ-12 is the one. If you've got more nuanced questions and you think your population can answer up to 28 questions, then that's great. Then go for the GHQ-28. I think as a researcher, my kind of key plea to any academics out there is, we need to design research instruments that are valid, and by valid I mean that research participants can actually complete. And if we keep having, because the GHQ-12 is just one part generally of a research study, so there'll be more questions there as well. So if you're using the GHQ-60, it's very onerous for the research participants. You have to really think through that carefully and think, what is it I want to know, and can my research participants or my clinical participants actually reliably fill in this volume of questions?
All right, wonderful. Thank you so much for that very insightful answer. For all of the answers, I think we've run out of time here today. If we couldn't get to all of your questions, though, from the audience, I'd like you to know that the speakers and the team at Mapi Research Trust, they will follow up with you after the webinar. Though if we couldn't attend to, if you have some further questions, I'd recommend noting down our email addresses that we have here up on screen to follow up further after the webinar. I want to thank everyone for participating in today's presentation. You will be receiving a follow-up email from X-Talks with access to the recorded archive for this event. A survey window will be popping up on your screen as you exit, and your participation is appreciated, as it will help us to improve our webinar. webinars. Now, I've also sent you a link in the chat box, and with this link, you'll be able to view the recording of this event on this page, and you can also share this link with your colleagues when they register for the recording here as well. So I encourage you to do that. Now, please join me in thanking our speakers for their wonderful time here today. We hope that you found the webinar informative. Have a great day, everyone, and thank you for coming.
Thank you. Take care.